My name is Dr. Vivek Bhadri. I'm a medical oncologist and I work at the Chris O'Brien Lifehouse and also at Westmead Hospital. So my primary area of practice is looking after adolescent and young adult patients with bone and soft tissue tumours. I primarily use genomic testing to test a patient's tumour to look to see whether there are any genetic mutations within that individual's tumour that can be targeted with drugs that are available in the market. In the situation where someone has relapsed or they've got widespread metastatic disease that's not responding to conventional therapy, then genomic testing can allow us to find a more personalised treatment for this particular patient. There are certain situations where you could predict that genomic testing might be more useful earlier on in the course of someone's disease. So for instance, patients who present with metastatic disease at diagnosis, you know that their response to standard therapy is not great, and so they're more likely to relapse. And so you can start bringing up discussions around potential genomic testing earlier on in their therapy. There's another way we can use genomic testing actually, which is to test your germline. So that means testing for the genes that you are inheriting from your parents. These genes that can be identified through germline testing often give you an indicator of your risk of developing cancer or of developing any other sorts of illnesses. It doesn't necessarily inform you on how to treat the patient right now with the cancer that they have, but can certainly give them some indication of perhaps why they developed the cancer, are they at risk of developing other cancers, and also potentially giving that information to other family members as well. One of the issues with genomic testing is the time it takes for results, which can be 8 to 12 weeks. After that, we have to source a drug. If a target is found, patients need to find the funds to pay for that, and the drugs themselves generally have a significant number of side effects. Bearing all that in mind, I wouldn't use genomic testing for someone whose life expectancy is likely to only be weeks, because the results will not come through in time. Secondly, I wouldn't use genomic testing in a patient who is very frail, because even if a target was found, it would be unlikely that they would be able to tolerate the treatment. Some of the challenges of genomic testing include managing a patient and their family's expectations as to the likelihood of actually finding an actionable mutation that can be targeted. Secondly, even if a target is identified, is finding the funding to pay for the drug that targets that mutation. But thirdly, it's also managing a patient's expectations of what that drug might be able to do for them. In my experience, particularly with the tumours that I deal with, these targetable mutations are not an Achilles heel of the tumour, that by targeting them, the tumours melt away. Often families, particularly parents, will want to make sure that everything is done for their young person. So even if you say to them genomic testing may not show anything, they are still very keen for it to be done. The use of genomics in oncology is almost becoming routine now. We have a great understanding of some of the genetic changes within tumours as well as in the germline, and so integrating new technologies, new forms of genomic testing actually is pretty seamless within oncology. It's just seen as an extension of finding out as much as you can about the tumour to find an appropriate treatment for this patient.